with the compliance guy, Monday Compliance Roundtable, uh, here on LinkedIn, on Facebook, on YouTube, and then we will be streaming on our Riverside platform as well. And then if you don't catch the live episode, you can catch us on the restream on any of these platforms, or you could find us on Spotify or Apple or one of 80 other platforms where you get your listening entertainment from. All right. With that said, I get to welcome back my very, very good friends, and I'm going to do this in order this time. Stephanie Allard. God, you guys are all my favorite, but Stephanie Allard, because you're the best looking of everybody, I'm going to introduce you first. And then there's Jordan and, Scott and David. Joe, if you're listening, Joe Rivet, our very good friend who's part of the podcast on the Monday Roundtable. He's a bit under the weather today. He's been doing a lot of traveling, West Coast and every place in between. We hope you get to feel better, my friend. We definitely miss you on this episode. And if we venture off into anything where I put my foot in my mouth with a legal situation, I'm sure Joe will correct it for us. So with that said, and yes, I am in the green room today. I am not in my normal office. So David told me, looking at this green room, he said his breath felt minty fresh. So we're all off to a great start here today. Listen, we've got a great program in store for you. We have some outstanding topics to cover. We're going to really take on the issue with these RADV audits. We're going to take on the auto downcoding that was released by the geniuses at Blue Cross Blue Shield. And we are going to take on medical necessity. And we're going to really look at medical necessity today, both from a federal payer perspective versus a commercial payer perspective, because they are not the same. They don't determine medical necessity the same way. And if we have time, we'll talk a little bit about the collagen bandages and the successes that we're seeing with those. Last week, we got 2 more favorable findings from the ALJs on collagen dressings out of Texas. So we are really, really happy with those cases that we were able to argue before the Office of Medicare Hearing and Appeals. So with that said, let's go ahead and jump off. Stephanie, I'm going to throw the first question to you. RADVs, right? These audits that are going on, they're not really audits that pertain to the physicians and or non-physician practitioners or the health systems. It's really the insurance companies that are contracted with the Centers for Medicare or Medicaid Services looking for more money to be able to support the fact that they keep telling Medicare, hey, these claims are really complex. And now all of a sudden, CMS is coming out with the Office of Inspector General and the Department of Justice and saying, are they? Take it away, my friend.
So one of the things that I think of when you're referring to that, Sean, is some of the audit activity I've seen in other types of cases as well, where I'm starting to see, for example, UPIC auditors will reference past claims data. And there's a lot of this happening where they're not just looking at that note that they're asking you for, they're pulling a utilization report and saying, okay, where else are we seeing this? What is the frequency? What does this look like? And I bring that up because one of the big issues that's coming to the forefront now is in relation to how often diagnoses are reported. So a lot of times on the practice side, we have groups who are looking at annual wellness visits, for example, to try to capture as much as they possibly can. And there's different ways of doing that. But now we're seeing some questions about, okay, well, you said the patient has this vascular condition. Why did I not see this on any other claims for the whole other part of the year? Who is managing this for the patient? How are they actively getting treatment for this? So to me, I find it interesting because it's always been like this trickle down effect for the providers. They don't feel that pain initially. There's pressure coming from an ACO from the payer, whoever it may be. But it's very interesting now that they're starting to look at workflow and what we know the groups are doing internally to try to maximize, and they're going to try to tackle that workflow in some way, I think, or at least call it to the table. Oh, you're on mute, Sean.
Yep, I am. I muted myself out of respect because I knew sometimes I just start talking. So, Scott, I want to come to you real quick because, you and I deal with a lot of clients that continuously send us these letters from PsyOx or from these different organizations, saying that they are requesting 150 medical records or 200 medical records. And one of the things that I started to do, and you engaged with me on this, we started to write these letters on behalf of our clients back to these third party vendors stating that, listen, we are more than happy to comply. We will comply, but your request for these medical records is unrealistic. It's overwhelming. We have a skeleton crew, the cost associated with us having to, from a labor standpoint, from a materials standpoint, is beyond what we are capable of doing right now. And if you want this information, you need to bring your own printers, your own scanners, and you need to come to our facility and you need to do it. The other option is cut it down from 150 to 25, and we'll be more than happy to do that for you. And we've seen pretty good success with that across the board with some of our clients. So, I know you and Stephanie are both certified in HCC, and I know this, hierarchical coding is very important. But talk about, some of the guidance that you've been working with our clients on, and how have you been responding to these, and what have you seen as some of the outcomes?
Well, I think it's important that to speak to Stephanie's point, these should be conditions that you're actually managing or impacting your clinical work in some way. Like my feel for the providers in some respects when it comes to risk adjustment is they're sort of caught in this weird middle where the payer is encouraging them to code things that they may not necessarily be managing. And then when the government comes after the payer, the payer's going to be like, well, I don't remember. I don't remember having that conversation. So I think as a provider, it's important that you're actually managing these conditions. It's important that you are incorporating them into your documentation in a way that reflects that management and in a way that enables you to push back. So, to the point of, how you might use these codes one time, theoretically, you may have a diagnosis that you don't manage that impacts a condition that you are managing. And we should see that in the note, and you should document it that one time. I'm a little leery, depending on the condition, with this idea that you take the physical and you just sort of shovel everything in there that you're not ordinarily managing. There are things that you are going to manage or that are potentially going to be impactful on your clinical work that you may talk about at the time of an annual visit because the conditions are stable or they don't necessarily require management at every visit. But, the reason we're seeing a tightening of this, I think, is pretty obvious. There's a huge amount of spend behind this, and there's continues to be an extraordinary amount of uncertainty around when you are supposed to assign these codes. I mean, how many of us have talked to a physician who said, well, I've been told just add all these codes at least once a year. There's no conversation about, did you actually manage the conditions? There's no conversation about, is it relevant to your clinical work? Or if it is, that part of the conversation got lost, before it got to me. And so, to me, like, I definitely agree with you in terms of pushing back around the extraordinary burden of providing all of these notes, right? Because when you get these requests for risk adjustment, it's generally not send us this one visit from like October. It's generally, we want the entire patient file for all these patients for the entire year. And I definitely agree with pushing back on that. I also agree with finding ways to, when you are actually managing that condition or that condition impacts what you manage, making sure you're talking about that in a real way. Like one of the things I've talked about talk about the new E&M documentation guidelines, right? Not to get off topic, but I think it is related in that I describe these guidelines as being much more about the clinician's perspective on risk, the clinician's conversations about the things that they are managing and how it impacts the patient's overall health, which is different from counting the number of systems that you reviewed. And so I think when you bring that attitude into, at the end of the day, am I managing this condition? Is it impacting the condition or is it not? And the last thing I would say, and I've said this before, and I sort of said it a minute ago, is as the clinician, make sure you don't get stuck on that island where you're listening to the payer's guidance. You know, I've seen these letters before. Well, our records suggest the patient may have this condition, and if you're managing it, you should include it on the claim. And that has the potential to be a rug pull, right? Like if you're not managing it, then you have to say no, right? And I think when the payer sends you that letter, the easiest thing to do is comply, right? Like half the time I'm telling you, well, comply with what the payer's asking you. But this is a case where you want to be very thoughtful about how you're choosing which diagnoses you're putting on the claim relative to the encounter.
So David, or go ahead, Jordan, go ahead.
I think the other thing is, this is designed, the risk adjustment, to be kind of prospective, but all these audits and everything is so retrospective, and the amount of lift that you guys are talking about. And there's also a lot of people that depended on, third-party vendors to do some of this. They depended on software. They depended on other means for optimization. And so then now they're having to go backwards and double the efforts to try to figure this out. And so I think that's, the lift is just really, really huge to ask. And there's a lot of other variables. It's not as just simple as look and find out.
David, and I agree with you, Jordan, 100%. David, it's interesting. Why did the UPICs, and back when you were with the ZPICs, why did the program integrity contractors like those that you were with, why didn't they get involved with these RADV audits? Was it because there were other third-party vendors, or were the diagnosis codes just not something that you guys paid attention to? What's the rationale behind that?
So I think part of it is and usually the way the ZPICs and UPICs work, they were concentrated mostly on fee for service, because you actually had the medic that did the Part C and D audits. So it was the medic that was doing the Part C and D audits. What was interesting about the medic was a program integrity contractor that literally had no authority. So they couldn't assess overpayments. They couldn't do things. They would basically work through. It was more of a reporting agency for all your health plans to report things into, because they'd have to report up to the medic. But because that was in that managed care space, the ZPICs weren't really looking at it. Now that they've changed it and designed what they're doing with the UPICs, and now that they've eliminated the MIC portion, the Medicaid integrity contract, folded that all into the UPICs, they're taking those resources, and that's kind of now where they're starting to look at this stuff. They're starting to oversee the plans. And I mean, I was at NAMPI 2 years ago, and OIG was, or CMS was telling everybody there, we're coming after the health plans. This is what their new charge is going to be. But exactly like you guys are all talking about, and this is the one that, when I was thinking about this, Stephanie, you said it exactly right. It's the trickle effect. They've looked at the plans, and then now they're going to look at the provider. And to your point, Jordan, companies like Inovalon, those guys, that's all they do, is they go out there and try to get these things increased. But at some point, they're going to come after the providers, and that's what you're seeing now, because they are, to your point, Scott, if it's not in the condition, you shouldn't really be putting that in your notes. You shouldn't have that. And the liability is going to come to them.
Yeah. Okay. Well, listen, these RADV audits, I think it's interesting to see right now the blowback that they are getting from the Department of Justice, from the Office of Inspector General, from the program integrity contractors at the Centers for Medicare and Medicaid Services, saying, hey, wait a minute, you're overstating the intensity of these diagnoses. And again, I give this new administration headed up by RFK and, Dr. Oz and, Kim Brand, I give them a ton of credit for not only focusing on the providers, the physicians, the practitioners, the health systems, the hospitals, the DMEs, but also focusing on their own internal program integrity contractors to ferret out fraud, waste, and abuse there, which seems to be something that has been ongoing for a long time. All right, I want to shift gears now. And, I want to talk about sometimes how you just can't fix stupid. And as many of you know, there was a release by a particular commercial insurance company over the last week to 10 days, indicating that on July 1st, they were going to go live with the auto downcoding of evaluation and management services based on the diagnosis code. Well, as the carrier put out in their policy, and I posed the question, did somebody actually write this, or was this written by an AI? Because when you read it, you just found yourself, at least I did, I found myself scratching my head going, who would put something this dumb out, honestly? And the fact is, it specifically says in there, if you agree with us, you don't have to do anything. And if you disagree with us, you submit your documentation. So I'm going to stop there, and I'm going to come to you, David, first, because as the head of a program integrity contractor, if you sent a notice of an error rate out to a provider, and let's just say, hypothetically, the error rate was 20%, okay? And that 20% resulted in an overpayment of $2,000. And the practitioner, the physician, didn't appeal it. They wrote a check for $2,000. They sent it in. Would you guys consider that a fishing expedition to say, well, if they were willing to give us 2,000, maybe they'd be willing to give us 10,000, or maybe they'd be willing to give us 20,000. Now I'm not going to put you on the spot and make you look unethical in any way, because you're a very ethical guy. But listen, let's be candid. These program integrity contractors have to justify their $80+ million contracts that they get. So their job is to do what, David?
Yeah. You're there to identify overpayments, get savings, prepayment reviews, all that stuff. So I wouldn't necessarily call it a fishing expedition, but what I would say is, if it works, you're going to try it again. If you get the 2,000 from there, and then I'm going to find a scope of providers that look like that. And if I can get 2,000 out of 100 of them, hey, great. It's less effort, more recovery. It's a win-win.
So maybe it's not a fishing expedition. We'll call it chumming the waters for those of you who like to fish, right? We'll chum the waters to see what bites. We get to bite.
Yep. Yeah. So I was just going to say, we've had things where we've tried to do that they were 100% policy based and tried to basically do broad range denials, and it was not as effective as one would think. Even though you had the thing, there's a potential violation of policy and direct violation, there is still wiggle room. So I think inherently to do that, there's a lot of risk to try to think it's going to work effectively.
Yeah. This is one of the areas where I'm missing Joe today, because I'm not going to opine on the law. Now, Jordan, I may come to you, even though you're not a practicing lawyer. You do have a degree in law, and I'm going to come to you, but I want to come to you in just a minute. I want to go, Scott. I want to ask you this question. So how often do we have clients that reach out to us? And Stephanie, I'll ask you the same question as well. How often do we all have clients that reach out to us and say, I've been audited by ABC insurance company, whether it's a federal payer or commercial payer, whatever it is, and they've indicated that the error rate is 100%, or that it's a high error rate and there is a demand for overpayment, especially on evaluation and management services. What have you, and then Stephanie, same question to you after Scott responds, what have you seen as far as when you re-audit those medical records, what are you actually finding as an error rate from the auditor versus the error rate that the auditor is claiming the practitioner has? Does that question make sense? You're on mute, Scott. I got you. Go ahead. You're on mute still. So Stephanie, I'm going to let you take this one.
Okay. Percentage, but one thing I will say is that for me, it's dependent on specialty and what the billing pattern is of the provider. So for example, if I know that a lot of 5s are getting down coded, but then I'm talking with somebody in rheumatology, well, there's more chance that that's going to be supported if they're doing a good job documenting their time. So it's okay. Do they know how to document time? Do they have their statements? All of that. One thing that's been really interesting, though, is even in a specialty like rheumatology, there's a lot of downcoding happening as well from a 4 to a 3. So I don't generally agree with the auditors because, especially, rheumatology, we know how complex those patients are. If I'm looking at utilization data, I would expect to see a high volume of 4s and a very low volume of 3s for that specialty. So it's very, specific to those things, but I'm definitely not always agreeing. At the same time, providers are not always documenting, what we've always been telling them they need to. So it's not helping in this situation.
Yeah, Scott, go ahead. Let's make sure your audio's on.
All right, can you hear me?
Perfect.
Yeah, a little bit of technical glitchiness. But, look, I was going to say, look, once in a blue moon, they're right, but they rarely are right at 100% denials, right? So typically, they're looking at things in the way that is least favorable to the provider. They don't have a great understanding of, when a condition may be complicated or exacerbated. And look, I think going back to what we were talking about earlier in terms of chumming the waters, to me, as I say to our clients all the time, like a payer auditor is disinclined to do you any favors whatsoever, right? So on these initial reviews, when they find these high error rates, Sean, we've been involved in these before where we end up taking it to the next level of appeal and we get a total reversal or we get, a pretty substantial reversal. So, I think that as I would say to the providers, and I think Stephanie was alluding to some of this, it is important when you think about documentation. We always say you're not documenting for the benefit of the auditor or the reviewer, but when a condition is clearly exacerbated or a condition is clearly not at the treatment goal, you really don't want to have them read between the lines on that because they're not going to read very far. So it is helpful to state those things. But I'm very concerned when we hear about things like auto downcoding because, to your point with these reviews with high error rates, I rarely substantiate a 100% error rate. We usually substantiate something much lower. And that's when they're looking at the claim, right? So that if they're not looking at the claim, it's potentially even more problematic.
Yeah, and Jordan, I'm going to come right to you in a second, but I want to make this one point, right? When you're talking about something that is based on subjectivity, okay? And I think all of us sitting here agree that evaluation and management services are highly subjective, especially when you get into the medical decision-making component of it, right? Because what is moderate complexity to Jordan may be high complexity to David, or what's low complexity to me could be moderate complexity to Scott or Stephanie. So when I see an audit that is based on evaluation and management services, and they tell me that the provider has 100% error rate, I kind of chuckle because in my mind, I know from being trained in, advanced mathematics that it is statistically impossible or improbable to have 100% error rate on something that is subjective. Now, if you told me it was a technical issue and that they were 100% of the time applying the 51 modifier, and it should have been the 59 modifier, and that's what resulted in the 100% error, I'd say got it. Makes sense, because that's subjective. That's a technical issue. But Jordan, I wanted to come to you, and I want you to give us your thoughts on this. You know, going through the law classes that you went through, you know, and looking at something like this auto down code, doesn't it really come down to what's in the participation agreement? And if they're not complying with what's in their participation agreement, that there's a potential breach of their contract? Again, I'm not a lawyer. I'm posing the question. You know, I'd love to get all your thoughts on this.
No, you hit the nail on the head. You bring this up, and I think that's the thing is if they're using any kind of AI logic that's not transparent, we don't know whether it's founded based on AMA guidance. We have no insight into that. Then absolutely, you know, the claims that if they're not consistently that what's being adjudicated with those CPT guidelines, rules and regs, that they absolutely could be in violation of their contract terms, applying basically undisclosed editing rules if we don't know about that. The other thing is there's something called a reverse false claim. So false claims, under the false claims, it doesn't just apply to providers. It also applies to payers that they knowingly underpay claims. And so if they have a systematically automated approach that they use to basically drop those payments and drop what they should be doing, they very well may have a reverse false claims issue on their hands. And then the other thing that kind of comes to mind is, what about, you know, ERISA? I mean, obviously for like commercial plans, you know, again, they also have within those contracts that things are adjudicated fairly. And so if AI downcoding is actually being used, you know, what is the clinical validation? Is it biased towards just cost reduction only? So ERISA gets into that. And then kind of as you reach further, you get into the unfair claims and some of the bad faith, which kind of compound. But those are the biggest ones, but definitely within the contract. I think that's why you're going to see very quickly, as governance of AI becomes a very hot topic in DC, is you're going to see a lot of structure around this.
Now, one thing, Sean, I wanted to bring up, I don't know if you all are aware of this, but as I'm talking with different clients of mine, and then some of my members are billing companies, things like that. So we talk about, you know, just different ways to identify this particular problem in your AR and in your reporting. And one of the crazy things is that not all of the payers on that remittance letter are showing in the CPT code that they've downcoded it. So initially, when we saw a lot of this behavior, we would see 99214 was billed, they put it to 213, they paid the lower rate. Now they're leaving the 214 in both spots, and it's just a lower payment rate. So it's even more difficult because if you have like the average person on your billing team working these claims, they don't know what your negotiated fee schedules are. They don't know what that's supposed to be at. And it's just happening in the numbers. So it's even harder to track and find ways to combat this. It's really getting out of hand.
No, you raise a great point. And, you know, Jordan, I want to go back to what you were talking about with ERISA, right? Because one of the things that I hear my very good friends, Don Self and David Zetter, discuss is whether a state law challenge to a denial of medically necessary care is preempted by ERISA. And, you know, there is precedence, if my mind is working correctly today, you know, whereby the Supreme Court held in Aetna Health versus Davila is the case, if I'm not mistaken. I think that dates back to like 2004, 2005, if I'm correct. That if an individual could have brought the claim under ERISA, which is subsection 502A1B, if I'm not mistaken, and no independent legal duty is implicated, well, the state law claim is completely preempted, right? So if we're looking at Davila, you know, the Davila case, you know, it's critically important, because so many of the commercial disputes over medical necessity are really in substance claims for benefits under the plan, right? Because the insured seeks payment for care the plan says is not covered, or not covered absent medical necessity criteria being met. I mean, you're somebody else who knows ERISA pretty well. I mean, is my mind on the right track when I'm thinking about Aetna v. Davila and the way that these plans work from the state perspective?
No, absolutely. I mean, exactly. Your talk on preemption, I think, is dead on. I mean, you're assuming, and a lot of these assumptions are, hey, we're not going to pay you, and it's based on the lack of, and that's the majority. It's based on the lack of medical necessity. And what is the medical necessity? Well, again, if I flip over to how does this process work? And well, if it's an auto downcoding that uses some kind of algorithm to say, hey, the medical necessity is not there, without any review of the subjective nature of the documentation, which is there, just like we talked about. I think that's extremely, you're basically just classing and saying one size fits all. And that is not the way it works. And that's not due process under the law. That's not due process for each individual claim. And the payer themselves has a fiduciary responsibility to be able to go back, and that's also within their contract. And I think it's important. You mentioned this earlier, is know your contracts, because it's in their contract to provide that fiduciary responsibility to review on a claim by claim, not just a one size fits all basis.
You're on mute, Sean.
Yep.
One
Once
other
again,
thing
I'm on
too
mute. Go ahead.
that I find interesting is that when you read these policies, if they put it in writing, some of the payers are doing this and they're not even putting a policy out. But if they have a policy, they go to the extent of listing all of the AMA E&M guidelines, which none of that you could even come to the determination of without looking at the note. So it doesn't make any sense.
No, you're right. And I want to go back to a term that Jordan used. And while I was on mute, I was trying to say it. The term fiduciary is an incredibly important term, right? Because a fiduciary is a person or an organization that has a legal obligation, if you will, to manage money or the property, in the best interest of another party, right? So they're trying to ensure that they are prioritizing a client's interest above their own. And you talked about due process for the claims, and it's unfortunate. I was talking to a group of law students, a week ago or 10 days ago, whatever it is, and one of the things that we were talking about was, the justice system says you're innocent until proven guilty in a court by a jury of your peers, right? Until you're found guilty by a jury of your peers. In the healthcare system, you're automatically guilty until you can prove yourself innocent. So your claims are automatically considered to be, wrong or errored or whatever, until you can prove that these claims are accurate based on the process that these insurance companies like Aetna, I'm sorry, like Blue Cross Blue Shield are trying to put in place, where they are auto downcoding your claims until you submit documentation to prove that they are substantiated based on the service provided. I mean, Scott, am missing the boat here?
No, I mean, what it's really doing, which is particularly insidious, is it shifts the burden of that claim review to the practice, right? Because it basically says, well, I'm just going to take the money. If you want to look at the claim and figure out if you think it's actually a 4, like, you can do that. But if you don't, like, I'm just going to take the money. And to your point, like, there's no way you can make that determination strictly off of the claim. Like, there have been some more specific diagnostic coding work, right? And I will say, I think it's important. There's a piece of this, where it is important as a practitioner to understand the diagnosis codes that you use most often and the specificity of those diagnosis codes. Like, how many times do you read a note where the provider is treating anxiety and the provider's been treating anxiety for 3 years and it's F41.9, right? And it's like, well, anxiety unspecified. So yeah, that may happen sometimes, but we haven't done any additional workup to determine if this is even like generalized anxiety disorder. So look, you have to do some of that work, I think, as a practitioner, as part of your defense of this. You do have to understand, like, if we toggle through diagnosis coding errors or concerns I see most often, like how often does the provider diagnose I-10 hypertension and then put like N18.31 in there? And so you're not helping in that situation. But at the same time, to me, this is just the payer saying, well, rather than having us look at all these claims to decide which claims we want to downcode, we'll just downcode them all and we'll let you do that work and you can come in. And to me, like, if I would be lobbying my state legislators and saying, look, we should have a law in this state that if you want to change the value of the claim that I've submitted to you, you need to at least come and look at it, right? You need to review the claim and make that determination, as would be the case for any other type of insurance product that exists.
I think that's bottom line. I think that's where the courts would find something arbitrary. You know, you hear the term arbitrary and capricious, but when you look at something like this, the downcoding of the AI process, basically that creates the vulnerabilities for the payers, because, you know, there is no individualized review of the claim. They're just relying on some generalized methodology that they can apply, to your point, Scott, just apply to everything. And they don't explain, you know, why a specific E&M level was reduced. And so if that payer can't articulate and say simply, hey, this is exactly, you know, the clinical rationale, it applies to these specific CPT codes, and this is how it's aligned, and these are the actual documentation gaps, and this is what would fill it. I mean, if that gets on up there to the courts, that's the true definition of being basically being arbitrary.
Yeah.
You know, so we started talking about medical necessity, and David, you know, I want to kind of bring you into this, right? Because I know and I always feel like I'm picking on you, David, because you came from the dark side. You came from the evil empire.
I was going to say, you
know,
often
now you're
refer to
part
it
of
as
the
evil
Rebel Alliance. You're part of the Rebel Alliance, right? For those of you who are Star Wars fans, you know, and David's a great guy, and David does a ton of work with me on our legal cases and, you know, our appeals and stuff like that. He's a prolific expert in these areas, and that's why I love to, you know, come to you with this stuff. You know, medical necessity is the overarching reason that the payers use to deny claims, right? But yet no payer really comes out and says, well, your claim's not medically necessary, because they just say the service is denied because it's not medically necessary, right? And for me, I think no matter how you slice it or you dice it, medical necessity is the issue all payers, irrespective of the type, hide behind, hide behind as a denial. And I think the reason is simple. And you tell me if I'm wrong on this, and if I am, you know, why. For me, when I think about it, medical necessity is the central coverage concept in both Medicare and commercial insurance. However, the legal source, right? The decision maker, the review framework, they all differ significantly. So, like, as an example, because you were with CMS, you know, under Medicare, coverage is generally determined based on whether the service falls within a benefit category and whether it fits under the reasonable and necessary standard under the act, right? Whereby commercial payers are governed primarily, as we were talking about a moment ago with Jordan, by the plan terms or policy language, which is why you must read and understand what is contained within the agreement. So if we're looking at Medicare, right, and we're looking at commercial payers subject to applicable state insurance laws and for ERISA plans or federal preemption in the terms of the plan documents. I mean, am I wrong in saying that medical necessity is used because it's so easy to hide behind, because it's never been really well defined, other than, I mean, we've had a couple of court cases where we've had some precedents on it, but it seems like it's pretty much ignored.
So from my perspective, and again, I never liked medical necessity cases just for that very reason. It's a very, there's a lot of, like, I just call it squishy. There's a lot of information. There's a lot of things that are contained in there. And usually it got into a documentation battle. So Scott and Stephanie, you guys have been talking about this repeatedly. If you got your documentation, 9 times out of 10, you're going to be able to support this. But I never liked medical necessity cases just for this very reason, because they end up, and this is what I think is interesting, if you're going to auto deny these codes, you go from a 4 to a 3, what's that, $8 to $10? So I mean, you're fighting over a smaller amount of money as it is that they're trying to go with. And the other thing that I think is dangerous, especially with the auto denial based on a medical necessity, is, to your point, Stephanie, what I heard from you was really alarming, is they're not changing the code itself, they're just changing the dollar value. You know why that is? The provider's not going to know to appeal that unless they're paying to, now they're going to have to go down to the dollar value. So that to me is something is kind of nefarious to be doing that. The other thing, potentially, are they going to create a situation where they're going to cause a provider to say, if this is going to happen, then I'm going to change my billing. And it's not going to be because they want to get, they're trying to say, just, I need to get out of this AI mess that I'm in. That's going to create another problem, because Scott and Stephanie both said it. Is that actually what you're managing, or are you just trying to get around this mess so that you can at least function as a provider? So I think it's almost like setting a trap in some ways, because I think you're going to create a situation where that's going to happen, where a provider, because they'll learn quick. I mean, we know in all the trending I've done over the years and going and watching the providers, they learn very quickly where these things are, and they will change their habits. But that change now is going to be the setup to say, now we're going to come after you because you intentionally did something.
David and Stephanie, you both Stephanie raised such a great point, and David, thank you for addressing that and articulating it the way you did. I think that's something that our listeners need to pay very close attention to, is that they're down coding the level of service, but they're not changing the code. They're only changing the remuneration. They're changing the dollar amount.
Like, how do you even appeal that, right? Like that the point that he made, it's like, okay, I'm appealing the 99214 that you're claiming you paid me a 99214 because all my other 99214s are 115 and this one's 80.
Yeah, which means you got to be able to go back, and you have to be able to understand or know what your system has as a fee for that particular plan from that particular payer. And Stephanie, you're a super user in some of these EHR systems. Is there a way to flag claims as they are being paid if there's a variance between what is typically paid for a level 4 versus what is now being paid? Is there a way to do that? Do you know, or is that something that is going to be? Go ahead, please.
So there is, and I actually met this company. I did a webinar and they sponsored it, and I was so excited when I heard what they did. I asked the woman to meet with me later. It's Claim MD. You may have heard of it before, may be familiar, but the thing that I liked about it is a third party, so you would have to, engage with them separately, but they give you autonomy to oversee your own information. And I say that because it's not as simple as knowing what your fee schedule is. Think about this. Think about how many people have an external billing company. And then on top of it, I've had some pretty big issues this year with clients because the billing company they owned the license to the software of the practice management system, giving them even less visibility. And they could only see, I came in and said, okay, I need to see these things. oh, you can't have that because if we give it to you, we don't have a way to restrict it so that you can't see everybody's information and what you're asking for. And we had a very narrow view of what this company's doing, what's happening with the claims. So you have to think broader because it's not as simple as knowing that information. So with this Claim MD company, they do a lot of work with the clearinghouses and making sure that you're set up if you have, something like the Change Healthcare breach that affected so many people. But one of the features of what they offer is that oversight where they're helping you on the provider side to automate that so you can better watch over your claims because right now it is so manual for the most part.
All right. So, so I guess, and again,
It's
without
a
trying to get
mess.
into it is because I'm sitting here and I'm thinking to myself, gee whiz, we pay all this money to these EHRs, but now we got to rely on a third party company.
Mhm.
And God bless them for figuring it out. I mean, that's the great thing about being in a capitalistic society, man. I mean, you create a program and there's a need for it and people are going to use it. But why haven't why haven't the EHRs, and maybe I'm asking the wrong question, I don't know. Why haven't the EHR vendors created a process to allow the end user who's paying a licensing fee to safeguard and to have access to their payer information? Why aren't they putting something in place to be able to say, hey, you're trending for what you have typically been paid by commercial insurance company A, PPO
Mhm.
has significantly changed and it's resulted in a delta of X.
But so don't you think, and this is my thought on this right now, but again, when we look at practices, especially if it's a small practice, they're wanting dirt cheap prices, the cheapest they can go a lot of times. So they're cutting themselves off from their own tool. And in this situation, which this goes into a whole other problem in the industry, but with this particular client, I knew I was going to have issues when I started to work with them because their percentage they were paying for the billing services was insanely low. And then you look at the company and they've got massive administration, over 20 people in a C suite is insane at a dirt cheap price. It's only happening by going offshore. They're trying to use the cheaper things available. They're not giving you access. But overall, it comes back to a practice as well, not understanding what this can turn into until it's
Yeah.
too late. So they look at the upfront costs, they don't want to pay for it. And I think we're going to have to see more competition between these companies because right now it's all structured from what I'm seeing as an add on and it's just
Yeah.
not being picked up.
One of the things that I'm seeing as a trend in the local markets where I am, and I'm seeing it kind of around the country as well, with certain clients that I'm working with, they are creating these partner programs. So the hospitals where they have, excuse me, um, relationships with physicians in the local community who refer to the hospital, do procedures there, etc. They are actually putting them onto Epic, and
And
under
it's
the safe
awful.
harbor,
I've seen it. It's awful.
under the safe harbor for the AKS, they're able to do it, and under Stark, they are able to do it as long as they only pay up to 85% of the cost for Epic, with the provider making up the other 15%. I wonder if at some point providers don't start inquiring with the CEOs or other C-suite members of the hospitals to say, hey, how do we get onto your contracts? How do we get onto Epic? And how do we really form this partnership so that we know that we're getting paid in accordance with what the contracts are? Because the hospitals are monitoring that because they have the staff to be able to do that. I mean, Scott, Jordan, David, are you guys hearing or seeing anything about this either?
I mean, I'm definitely seeing situations where, group practices are using Epic via like a hospital provider, like in some cases. I mean, I don't know that they're doing it for that specific reason versus just more synchronicity with the places where they work.
Well, and they get access to their data and to their numbers so they can create better benchmarks and stuff. I mean, obviously there's a win for the hospital, right? Because they're
Oh
not,
yeah.
contribute 85% of the cost of the Epic. I mean, there's got to be a win in there for them, right?
Yes, nobody, as my dad once said, nobody does anything for nothing these days. Any day.
And I know that came out of your father's mouth because I've had dinner with that guy.
Yeah, yes.
mean, I
Well,
think-
and
Go ahead.
I was
Steph.
just going to say really quick, just to caution people who are looking into that, one of the reason that I say that it's awful when there's this integration is because it limits the practice's ability to do anything. I've done audits where the way that templates are set up and the way that some of the billing edits are set up is causing non-compliance, and their hand was tied because they didn't have ownership. Again, someone
they're not
else
a
has
super
that
user.
license.
They don't have ownership. Yep.
Yes,
what I was
so
gonna
you
say.
can't fully trust even a
it-
hospital.
It adds to the laboriousness, frankly, sometimes of just on there.
Yeah, they're giving up the
Yeah.
rights a lot of it, to Steph's point, just in the name of price to pay less. They're giving up their rights of oversight and control, which can turn around and bite you.
Yeah, I will tell you this though, and I want to be very careful. Terry Fletcher, my very good friend, she always yells at me on our hashtag Terry Tuesday episodes because I always find a way to say something, and she's like, "God, could you please cut that out at the end?" So Terry, if you're listening, this one's for you. Um, you know, so many of these EHR companies that were they were really good when they started out, and I'm not going to mention any names. I'm not. They wound up selling, and they sold to companies that are now offshoring all the customer service. And I'm talking about some that were really considered to be the Rolls Royce of EHR at one point, and I'm not going to say any names. But those EMRs, those EHRs have become, from a tech support standpoint, a customer service representative perspective, they have become so substandard in what they are providing. And it is creating a giant vacuum right now in this industry. And I get calls from providers every single day. I'm being nickeled and dimed to be able to do this, to do that. At some point, the government is going to have to take a look at these templates that are being created by these EHR companies that are prompting physicians to document in a certain way to capture the algorithm built into their coding wizard that is often pushing them to bill level 4s or level 5s just based on an algorithm, not taking into consideration the same argument that we're having here on the downcoding. It's on the overcoding side with respect to, it's not taking into consideration the clinical judgment, the medical necessity, the appropriateness, the reasonableness of the service. And these templates are going to, if the providers are not pushing back on these EHR companies and saying, you guys are potentially putting us into a False Claims Act situation by driving us to certain levels of service based on an algorithm, I think the DOJs and the OIG are going to get very interested in this. I mean, David, I'm going to give you the last word on this one because you were part of program integrity at the highest level as the senior director of these agencies. I mean, talk about that for a moment, please. What was the perspective that you guys and ladies had at program integrity when it came to these templates that are being created by these EHR vendors and the tie into an algorithm to get it to a higher level of service?
So to your point is the idea that, they're being pushed to do this. So yes, it's driving them to a potential false claim. The problem is that, it may help their job get easier, but to your point, it puts them at liability. And coming in as a contractor, I'm like, hey, this is your vendor. You're responsible for managing your vendor, just as I'm being responsible by CMS they're managing their vendor. So to your point, they have to come out and say something, because at the end of the day, saying, well, this is what they gave me. Well, you accepted it. You now accept the risk and liability that comes with it. Now, we have had situations where we actually did go after a third-party vendor, because what was happening was they were actually changing things on the back end. So they were upcoding without the provider knowing about it, and then they were keeping, the difference off the top. So it's rare, because they actually had, unfortunately, for them, where we could see where they were changing the codes, because the doctor showed us what they billed, and then we got to see what came in from the EHR. So we got to see the variance, which allowed us to go after the organization. But if they're doing it through a template, the risk is still on the provider. But to your point, manage your vendor. They work for you. Even if the price is low, they work for you, because if not, you will be, you're going to take the risk.
Well, and I think, just to build on that, that's where internal compliance comes in to some extent, because the provider, I don't know that the provider always has a great sense of what is right and wrong in the way that, like, we do, right? So if you go to the provider and you say to the provider, well, this is going to help you achieve the right code by doing this, this, and this, and the provider might just say, well, okay, that must be how we do it now, right? Like, I don't think the provider always has that level of sophistication, whereas the provider just says, well, this makes my life easier. I hate documenting anyway. And so somebody in compliance or administration has to be more on point to that, because my worry for the provider, as I talked about in a different topic, is provider gets caught sort of in the middle, right? Because the administration and finance wants more money. I mean, how many providers will talk to us about the pressure they get in-house to see more patients, to do faster appointments, to code higher? And so you see that tool and you say, well, that tool makes my life easier, right? And one last thing I wanted to say about what David said earlier that I think is important is, a lot of this algorithmic auto behavior, and this is one of those things that gets us further away from what medical necessity truly is, and more into the idea that, like, well, I have to document this either because they're taking away from me on the left hand, so I have to make it up on the right hand. I did the opposite hands there, but you know what I'm saying. Or they just are being sort of pushed to rote things into the note that they don't think are necessary. This came up in risk adjustment, where I've had providers say to me, well, they tell me to manage diabetes and hypertension. They tell me to write it in every note, but I don't even manage that, right? And the provider doesn't know that that's wrong in the way that, like, we do. And I think that's a challenge.
Excellent points, everyone, all the way around. What a great discussion. Thank you all so much. All right, that's going to wrap it up for this episode of the Monday Compliance Roundtable. I want to thank Scott, Stephanie, Jordan, David for being here today. Again, to our very good friend, Joe Rivet, I hope you are resting up and getting well, my friend, and we'll see you back here in a couple weeks. All right, to each and every single one of you, thank you so much for tuning in, logging on, and hanging out with us on this episode of The Compliance Guy. We're going to be back in 2 weeks with an all brand new episode, and we should have everybody back by then. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.